Well, hello and welcome again to the Scholars webinar on cardiology, innovations in the treatment of cardiac disease. Now, we would like to start the speaker session, and I would like to call upon Dr. Simova of the Heart and Brain Center of Excellence at the University Hospital in Bulgaria to deliver her talk entitled Cardiovascular Complications of COVID-19 Post-COVID Syndrome. Dr. Simova, please.
Thank you very much. First, for the kind invitation to be part of this prestigious Congress. Thank you all the moderators, all the audience. Can you hear me well? Can you see me? I suppose yes. So I'm going to share my screen and begin with the presentation. So, dear colleagues, my talk would be about the cardiovascular complications of COVID-19 and about the post-COVID conditions. I have a problem with switching between slides. Let me see. If you give me some tips. Strange. Just a moment. I will try to share the screen again. Maybe in this mode. It would be easier. Can you see my screen now?
Yeah, we can see.
Okay, I will try this this mode. So I'm going to speak about cardiovascular complications of COVID-19 and post-COVID conditions. We know that for a second year now, the whole world is ravaged by the SARS-CoV-2, and we are now more and more confronted with the challenges of the post-COVID-19 conditions. Another term for these conditions introduced by Anthony Fauci is the post-acute sequel of SARS-CoV-2 infection or PASC. But the common definition is that these post-COVID conditions comprise all signs and symptoms of COVID-19 that persist after the acute phase, the third or the fourth week, without an upper limit of longevity as for the present state of knowledge. And as you could see by this timeline, the acute phase ends about the third or the fourth week, and after that there are no replication competent SARS-CoV-2 viruses isolated. So how long do these post-COVID conditions persist? We now have data that they could persist for up to the 9 months, but for so long we still have follow-up data, but probably and unfortunately with further data gathering we would find out a considerably longer duration of post-COVID-19 problems, maybe up to the second or the third year after the acute phase, as World Health Organization experts believe. Here I would share a very brief personal experience. Last month, March 2021, I examined one of the first patients who had COVID-19 in our country in March 2020, and this patient repeated still, I'm still not the person I used to be, so 1 year after the initial phase. What is the clinical presentation? I should say here that it should be highly variable with clusters of symptoms which can affect any system in the body, often overlapping, typically fluctuating and changing over time. According to the pulmonary, there could be dyspnea, diminished exercise capacity, hypoxia. Hematologic complications could include thromboembolic events and also long a long hyperinflammatory state caused by the SARS-CoV-2. Neuropsychiatrists are the most common symptoms, and they may include fatigue, myalgia, headache, dysautonomic dysfunction, cognitive impairment, anxiety, depression, sleep disturbances, and so on. For those of the patients who have had an acute kidney injury, at the initial phase, there is a typical prolonged decrease in EGFR at their follow-up stages. Endocrine sequelae may include new or worsening control of existing diabetes mellitus, subacute thyroiditis, and bone demineralization. The gastrointestinal system is very important because there could be a viral persistence in the gut, and also because COVID-19 has the potential to alter the microbiome of the guts and to lead to depletion of beneficial commensals in our gut. There could be also skin problems, ear nostril problems, and of course, my main topic would be the cardiovascular conditions. They could include palpitations, dyspnea, chest pain, variability in the arterial pressure, which could be sequel of increased cardiometabolic demand, myocardial fibrosis, or scarring, and also autonomic dysfunction. So it is clear that for these patients, for sure, we need an interdisciplinary management, and mainly some COVID-19 clinics devoted to the post-COVID conditions to cope with these many situations. Sorry. What do we know about the pathogenesis of these post-COVID conditions? Here, another important aspect to consider is that millions of people worldwide are suffering from a condition that we still do not fully understand. And according to the World Health Organization, there are several possible mechanisms responsible for this post-COVID-19 conditions. One of them is the inflammation, the ongoing immune stimulation from reservoirs such as the gut of persistent infection. Another one is the dysregulation of the immune system with paradoxical hyperinflammation or autoimmune infections. Also, there could be impairment in the blood clotting system and in the small vessels, and there could be endocrine and metabolic disturbances. The exact number of the post-COVID conditions is very variable in different studies. It ranges from 10% in the general population to more than 87% from inpatients discharged from hospitals. So even assuming a relatively optimistic number that every 1 in 5 people infected by SARS-CoV-2 would suffer from post-COVID-19 condition. Extrapolating this number, 20%, to the hundreds of millions COVID-19 cases, it still means that a considerable proportion of the world population is and will be affected by the COVID-19 conditions, and that equals 26 million past cases worldwide as of April 2029. So, of course, these post-COVID conditions have and will have enormous significance for the healthcare and the economic systems in the upcoming years. This comes not only from the simple fact that they're highly prevalent, but also from the fact that they affect people regardless of age, including young and active people, and regardless of the severity of the acute illness, even after asymptomatic cases, and that we still must learn a lot about its pathogenesis, natural history, treatment, and prognosis of these patients. And having said all this, nevertheless, just less than 1% of the ongoing clinical research is focused on COVID-19 conditions. And that's what we do. And in the second part of my talk, I will share some personal experience. That's what we do in the Life After COVID campaign of the Bulgarian Cardiac Institute. This institute is the leading cardiological organization in Southeastern Europe, and it includes 7 hospitals and 15 medical centers in our country, Bulgaria, covering the 3/4 of the country's territory. So, September 2020, we started the initiative Life After COVID, a national free of charge campaign for the evaluation and treatment of cardiovascular consequences of COVID-19. As for now, we have evaluated more than 1,500 patients. We start with a short survey with the following simple questions, such as, do you feel more tired? Do you still have cough, shortness of breath, chest discomfort, palpitations, headache, dizziness, loss of concentration, and so on? And from the answers to the survey, we found that 66% of the people who responded have still fatigue, 49% have chest pain, 41 have palpitations, and 31 have shortness of breath. A significant proportion of these patients had more than 1 and more than 2 symptoms. We have evaluated, we have examined and evaluated the data of 808 patients, and from their findings, we could say that the most common physical finding was a variability in the blood pressure in 51% of the cases, followed by arrhythmias in nearly 1/3, and manifestation of heart failure in 15%. These findings necessitating an additional research in 65% of the cases, and led to a change in the medical therapy in 62% of the cases. Another important observation, something that usually the patients do not feel, but we find very often, this is a characteristic change in the deformation of the myocardial, the inner strength of the myocardial, the so-called strain assessment, which is decreased in a typical pattern in the basal segments of the heart. That's what I used to call the typical imprint of the SARS-CoV-2 on the heart. I have personally examined 250 post-COVID-19 patients with echo and with staple tracking imaging, and I found this typical imprint of the SARS-CoV-2 on the heart in more than 2/3 of them. And here I would like to share with you example. This is about a young 43-year-old man without comorbidities, with a healthy lifestyle, non-smoker, training actively 5 times weekly. He came to me 1 month after being hospitalized with COVID-19 pneumonia and asked for consultation because of a stabbing chest pain. Everything was quite normal in the examination. Apart from what you see in the figure, this is the bullseye strain, which showed a decrease in the GLS to -16%, with a typical decrease in the basal segments in a non-ischemic pattern. At this time, I started the patient on a cardioprotective therapy, prolonged the anti-thrombotic medications, and initiated an antiviral therapy, hydroxychloroquine. I counseled the patient at this time to live a normal life, but to restrain from extreme sport activities and from competitive sport, and to schedule an examination in another 3 months. He came to me and he was then in excellent health. All his complaints have receded. Echocardiography was perfectly normal. All the segments were normal. GLS was -21%, which is totally normal. And at this time point, both me and the patient felt quite comfortable to stop all the medications and to allow for a full training program to these patients. Another important aspect in our campaign Life After COVID is about the acute coronary syndrome during acute or post-acute COVID-19. Why this is important? You know, many patients hospitalized with COVID-19 or at home with COVID-19, when they have chest pain, there are very organizational technical issues how to hospitalize this patient in a cardiology, in an ICU, and to transfer the patient to the cath lab. So it is very important to know exactly which patients with COVID-19 and the clinical picture of myocardial infarction really needs to be sent to the cath lab. And here we observed 10 consecutive patients with COVID-19 who were admitted with a confirmed diagnosis of MI. Mean age was 68, half were female, all had hypertension and so on. And 30% of these patients with a confirmed myocardial infarction did not have an infarct responsible artery or ERA and did not need a PCI. Patients who had an MI and an ERA had significantly higher high-sensitive troponin values, 49 as compared to 0.6, and exclusively typical chest pain compared to patients with MI but without an ERA. ECG changes did not show only marginal statistical significance. And we suggest that in this setting, COVID-19 patients with chest pain and confirmed myocardial infarction using a higher than normal cutoff value for high sensitive troponin more than 7.5 times higher the upper limit of normal increases the specificity and positive predictive value for the diagnosis of a myocardial infarction with the presence of ERA and the need for a PCI to nearly 100%. Another important aspect is the anti-ischemic therapy in patients with COVID-19 who had acute coronary syndrome. Here we have evaluated 20 patients with COVID-19 and acute coronary syndrome. All of them went coronary angiography. In 55% of them, we found a coronary lesion which was responsible for the myocardial ischemia, and in the other 45% of them, there were not significant coronary artery stenosis. In all of these patients, we started anti-ischemic therapy with moxidumine, with perimetazidine, with beta blocker, in addition to anticoagulant, antilipemic, and other necessary medications. During the hospitalization, angina symptoms were resolved in all patients except one who required an additional PCI. During the 1 month of follow-up, all patients remained asymptomatic and without subsequent hospitalization, and this reduction of the angina symptoms was evident both in the patients with a need for a PCI and those without significant coronary artery stenosis. So, as a conclusion of this study, we could say that a significant percentage of patients with COVID-19 and acute coronary syndrome do not have coronary lesions, which suggest here the presence of involvement of the small vessels of the heart. And is in this subgroup, the administration of anti-ischemic therapy with beta blockers, moxidumine, perimetazidine, in combination with anticoagulant and antilipemic therapy, results in a rapid resolution and lasting response to angina symptoms. And last but not least, the acute pulmonary embolism during acute or post-acute or post-acute COVID-19. This is another important problem because, you know, many patients with COVID-19 have symptoms compatible with pulmonary embolism, and we are placed at the dilemma if we should send the patient to the CT and eventually to the cath lab. So here we set ourselves the task to find which are the predictive indicators for the correct diagnosis. We studied 27 patients hospitalized with COVID pneumonia. All of them received anticoagulation and antiplatelet medications in the hospital, and pulmonary embolism was confirmed or dismissed by CT pulmonangiography. So the mean age was 65, but 2/3 were women. 8 of them had a confirmed pulmonary embolism. Here we found that ECG parameters and echo parameters still remained predictive for the presence of pulmonary embolism. More important were D-dimer values. The upper limit of normal for our lab is 500, and as you could see on the left of the slide, the patients who did not have pulmonary embolism but had COVID-19, they have mean D-dimer values of 1500. Compared to those with pulmonary embolism and COVID-19, they had D-dimer values of nearly 6500. So with this ROC curve that you see on the left, we find that the optimal D-dimer cutoff value with the optimal sensitivity, specificity, positive and negative predictive values for the diagnosis of pulmonary embolism was 1032, 2 times greater than the upper limit of normal. And we performed logistic regression analysis in which we found that ECG parameters and D-dimer values were the only predictive indicators for the correct diagnosis of pulmonary embolism. So we suggest that a higher D-dimer cutoff value should be applied in COVID-19 patients and post-COVID-19 patients in order to confirm or to dismiss the diagnosis of pulmonary embolism. Dear colleagues, our work on post-COVID-19 conditions is only in its beginning. Understanding post-COVID-19 conditions is of crucial importance for the near future of the mankind. There are so many questions that we should strive to seek an answer to, but no one, no patient should be left behind, and we should keep strong and we should keep going together. Thank you.
Thank you very much, Dr. Simova, for an excellent presentation. And now I'd like to open the virtual floor to questions.
Can you hear me now? Can you hear me now? Yes, yes, that's fine. I'm sorry for that. I just logged in from my mobile. So there is a technical issue from my laptop. So can you share your screen of your presentation? The one which is you opened is fine. We have to presentation. Okay, can you enable your video, please? So that like.
Is that a question? I'm sorry, but I didn't hear it at all. Can someone repeat the question to me?
Thank you so much, Dr. Simova, for a very nice overview about the cardiovascular complication for COVID-19. My question,
To the bottom, you can see there is a start video.
Okay.
There is some interference. Maybe two people are asking questions at the same time.
Yeah, better to leave the speaker only unmuted and other muted. So my question about the patient who presented by COVID-19 and he developed significant elevation in cardiac biomarker, troponin and proBNP and ECG changes. So in this case, because most of the intensive care doctors, they are so worried about the COVID infection, and they are maybe neglecting the biomarker, and they are saying this is mostly due to myocardial injury or sepsis. And in fact, some of this group of patients, they have clear acute myocardial ischemia. So if there is any policy to differentiate between myocardial injury secondary to COVID-19 infection and actual acute coronary syndrome?
Very important question, and that's what we were trying to see if there is some marker which could tell us which patient is suffering from a coronary thrombosis, which needs to be recanalized, and other patients who have some microvascular dysfunction and other pathophysiological mechanisms due to the COVID infection. And that's why we studied our study group, and we found that all these patients, all our patients had the classical criteria for a myocardial infarction with a rise in serum high sensitive troponin, with ECG changes, with chest pain, with echo CG changes. But we found that in order to expect a real coronary thrombosis with a need to be opened, recanalized in a cath lab, we have to put the cutoff for the high sensitive troponin at least 7 times higher that we are used to putting it in the normal conditions in a patient who has been at home, healthy, and not in the hospital or with COVID-19 pneumonia.
Yeah, actually, second, the question about the patient who presented by STEMI and clinically he is suspected COVID-19. Did you push this patient to cath lab to do primary PCI, or you will give lytic therapy and then to do rescue coronary intervention?
So we were only in the beginning of dealing with COVID patients at the time point we started gathering these patients. So all of the patients who had the classical criteria for a myocardial infarction and acute coronary syndrome, they were sent to the cath lab. With all the difficulties of sending such a patient to the cath lab, with the risk for the patient, the risk for the personnel, and everything else. And as we saw that many of these patients did not have significant coronary lesions, then we started to search which are the parameters which could distinguish the patients who really needed to be sent to the cath lab with an intervention, and those who just have the symptoms, but during the cath lab examination we didn't find an infarct artery, we didn't find a target for intervention. So at first, yes, we sent all the patients to the cath lab in order to have more data to decide which are these predictive parameters which could exclude some part of this cohort and consider that the others are more likely to have an MI with an occluded coronary artery.
Thank you so much, Dr. Simova, for this fantastic talk. Thank you so much.
Thank you too.
Would there be any other questions for Dr. Simova's presentation?